All right, I think we are live. So I hope I'm not echoing and everyone is hearing us just fine. And I know that our people will let us know if that's not the case. And okay, yep, I got the confirmation. So we're gonna go ahead and start. Good afternoon, everyone. Because it's our new setup, so I have to make sure I do everything properly here. So let me just change something here, and then we are going to start in 2 minutes. So, okay. And okay, and all right, so that's good. And then one other thing that I need to do, so then it can, all right. I think we should be good now, and everything should be in order. And if it's not, I'm not going to actually try to change it. So today is February 25th, Friday. It's our weekly event from United Medical ACO. Today, we are going to discuss, as usual, our vaccine update with COVID-19 pandemic, as well as we have a guest speaker on the clinical side. We are going to discuss non-surgical weight loss management at the primary care level. And also we have other topics, which last week we did promise we were going to continue on the economy and global crisis economy. And that's those are the things that we are going to discuss. But before we go to those, we are going to let Sean share the cartoon of the week with us.
Alrighty, yeah. So our cartoon here, again, always relating back to coronavirus, and this one's kind of taking a stab at the mandates and kind of the irony of that they're reopening their businesses and restaurants, and it says, spray painted there as it's all boarded up after 20 years out of business. So it's kind of just taking the step that maybe they waited a little too long, that a lot of maybe mom and pop type businesses or smaller ones were not able to actually hold out through 2 years now or so of this pandemic, and that the financial burden was just a little too much to handle. So that's kind of the idea and agenda behind that cartoon there, that was just a little overwhelming and just too much to handle for the financial.
We are hoping that they can find people to work.
That too.
Right. So let's start with our vaccine updates.
Yeah, definitely. So looking here, the U.S. is actually no longer in the top 5 of new cases across the world. So they are down less than 2,000 deaths are in that week, or past week, we're actually down to less than 2,000 deaths being reported. Looking at the overall trend with the curve there with our red line of best fit, it is definitely on a downward slope, very significant drop off there. And then vaccination wise, we are actually increased 3 million from last week. And then looking at the US versus Delaware percentages, again, Delaware looks to be up around 0.2% or so in each of those categories, with the above age 65 still leading the way at almost 93% vaccinated, and then totaling over 215 million now, and across the whole nation are fully vaccinated, with 93.5 having received a booster.
All right, so now I think from the vaccination standpoint, things are going to slow down. So the March is next week. So the winter season is over, flu season is over. So we know that things are going to slow down. So at this point, what's going to happen, what may be happening for next fall? Now, I'm actually so happy that we do record these events, because I'm actually so tired of just telling people, do you remember what I said? Do you remember what I said? Well, you don't need to remember. You can always go back and watch what I said. So the fall is going to be in September. It's too close. It will come so quickly. So we have to prepare and then make certain changes in order to actually be ready for the next flu season, next winter season. So those are the things that we have to be doing during this time, so that it's not going to be another trouble winter that we are going to have. So that's going to be totally up to us whether or not we are going to have a better season or not. So this is going to be totally up to us. So I think we got so much good habits in the last 2 years. I'm hoping that we are going to be able to go through some of these issues with less problems. That's kind of the hope that we have. Now, of course, we have different problems coming up on our way in the world. So, you know, one thing after the other. So this is going to be an ongoing problem, I guess, not just the health issues, but the other crises. So when you think that one is over, another one is starting. So hopefully that's not going to be the case. Now, today in our new format that we have a clinical guest every other week. And so far we did 4 events on the clinical setting, and today is our 5th one gonna happen. So I'm gonna let our guest in. So Dr. Vani Singh, and also my clinical partner, Donna Gankul. So we did not test the connection just because the way that everything is working is a little bit different now. Dr. Singh, can you hear me okay? Hey, Donna.
Hello.
How are you doing?
Good.
Dr. Singh, your camera is off. Not sure if you are able to hear us.
Hello. Hi.
Hi, how are you doing?
I'm good, thank you.
Good. So Dr. Vani Singh is one of our new providers. So I prepared this video playing on one of the boxes that you see. Dr. Singh, I did that all on my own, just for you. So I want you to introduce yourself. I know you are a family medicine, but then something makes you different than other family medicine, and I want you to explain that, and I just give some background on what you have done before joining United Medical Clinic, and then we are going to have the discussion on the clinical side.
Sure. Yeah. Thank you, Kemal. So hi, everyone. I am Dr. Vani Singh, and I am one of the family medicine physicians. I have certified in the pediatric medicine by the American Board of Obesity Medicine. I am very passionate about helping our patients reach their ideal body weight so that they can go have a healthy lifestyle and well-being. Yes.
So was there any specific reason you choose to certify in the bariatric medicine?
So I got interested in this way back when I was in residency, when we would see a lot of patients hospitalized for the in-hospital stay was a lot longer for patients who were overweight or obese, just because of the complications and recovery for every medical illness or post-operatively. So this is something I got interested in then, and realized that this is one of the big reasons why most of our patients have the medical problems that they do, the metabolic syndrome, and the healthcare cost and everything that comes along with it.
You know, it's interesting that until like 2010, morbid obesity was not even recognized as a chronic illness. and then things happen so quickly in the last 12 years. Now we are trying to catch up. As you know, we are also running the bariatric surgery program. And I personally have spent so much time in there, educate the people on morbid obesity, just to kind of fight with the prejudice of the people. Like, this is not a lifestyle, this is a chronic illness, just like diabetes. And after working so much, working with the surgeons so much, and we still do it, having a non-surgeon, someone like you joining the program, that was actually a huge plus for us, because we wanted to make sure that someone who doesn't have the surgery interest in this can actually explain this to the patient and educate the patients, help the patients. So I'm so glad that you are with us. So I know we prepared the clinical presentation, so I'm going to go ahead and share that, and I'm going to try to follow. Usually I'm good, but this, I'll try to make you say less next slide, but let's see if I can do that.
All right, great. So, so why treat obesity? So today I will be talking about the benefits of losing the excess body weight or excess fat that we have. But before I do that, I want the audience to really understand what is really obesity and why is it so important that we need to treat it. So obesity is a progressive, treatable, multifactorial disease, and it is basically defined as the accumulation of excess body fat that can lead to the various health conditions and diseases and metabolic syndrome. And so it's very important that we are targeting it and treating it so that patients have a healthy lifestyle. And as you can see on this slide, this is from CDC from 2020, and this is the prevalence of self-reported obesity in the US adult population. As we can see that the highest incidence that is reported is in our southern states, and whereas on the West Coast and also in the Northeast, the incidence is a little bit less. But there are only a handful of states like Colorado or Hawaii where the incidence is less than 20%, between 20 to 24%. So it is predicted that in about by 2030, 50% of our adult population might be obese, and about 25% of adult population might be severely obese, that is a BMI of more than 35. So obesity, we like to classify obesity to kind of figure out where everybody stands and how we can treat it perfectly. So BMI is the most common measure that we use to classify a person if they are obese or overweight or normal body weight. So BMI is weight in kilograms, and then we divide it by the height in meters square. When we do that, a person who has a normal weight or a normal BMI is between 18.5 to 24.9, that's what we consider normal. And anybody less than 18.5 is considered underweight. Anyone with a BMI of 25 to 29.9 would be overweight. And then coming to our obesity class 1, class 2, and class 3, excuse me, it starts at 30 to 35, 35 to 35, 39.9, and over 40. So these cutoffs are actually different for the Asian population. For Asian populations, we say overweight would be more than 23, and class 1 obesity would be over 25. Now, while BMI is the most easy method that we use to help classify obesity, it does have its own limitations because it does not take into account the muscle mass. Somebody with a very low muscle mass and a high fat percentage might still fall in the normal weight category, but they might still have excess body fat in their body, excess body fat. So that is one limitation of our BMI. Another limitation we see is it doesn't account for the gender and also, like I said, the race before the Asian population. Another way we can classify obesity is also the waist circumference. So, and that is the measure of the, so that gives us a measure of the abdominal obesity. And in men over 40 inches of waist circumference and in women over 35 inches of waist circumference, it has been noted that there is a direct relationship of that increased waist circumference to the cardiovascular risk and metabolic risk. And again, the cutoff is different for Asian men and women. In Asian men, we say over 35 inches and Asian women over 32 inches. So why is all this important and why do we care about it so much? Why do we care about how much body fat we have? So as you can see on this slide, that it is a risk factor for so many more diseases. It is, even though it's a disease and it's a risk factor for so many more, it can cause high blood pressure, diabetes, heart attack, stroke, and also with the physical effect of the body mass, they can be osteoarthritis, obstructive sleep apnea. It's also a risk factor for many different cancers, like the breast cancer, uterine cancer, and prostate and pancreatic cancer as well. And of course, the list is very long. As you can see, there's much more we could add on this slide. And so it does cause a lot of medical problem. Also, they say the body fat that we have, the abnormal body fat that we have, the risk for mortality is curvy linear. So anybody with a very low BMI of less than 18 or a very high BMI of more than 35, they are at risk for various health conditions that can lead to early death. So coming to our obesity treatment goals, for an adult patient who is overweight or who is obese, we like to reach certain goals. And one of them is to improve their body weight and also body composition, meaning how much body fat they have, how much lean muscle mass they have. And also we want to improve that. And also we want to maintain that weight loss and maintain that body composition once we've achieved it. We try to improve their health by improving their blood sugar levels, by improving their blood pressure levels, cholesterol level, and also preventing heart attacks and stroke. By doing all this, we are improving their quality of life. They are able to be more physically active, go out of the house more, and do the things that they like to do. And all this also helps with their body image, and it also helps with in the treatment of depression as well, because a lot of patients are depressed just because of not being able to do what they want to do, not being able to get out of the house, and some don't like the way they look, or so it improves a lot of things. By treating obesity, we can achieve a lot. So our data shows that only even as simple as 5 to 10% of weight loss from our body weight from maybe a starting can improve our health condition. So if someone loses 5 to 10% of the weight loss, has a 5 to 10% of the weight loss, their sleep apnea can improve up to 50%. And their insulin resistance also improves, and the insulin sensitivity improves as well. So there we are able to get better blood glucose control. We are able to get a better hemoglobin A1C, and also so improve the diabetes. Also, it improves blood pressure. So with the 5 to 10% of weight loss, we have noticed that there is a decrease in blood pressure by 10 millimeters. And the lipid profile is definitely a lot better with weight loss. The LDL and the triglycerides level improve we are able to decrease them, and also improve the HDL level, which is our good cholesterol. So, and all these things are a part of metabolic syndrome. All these things are a part of our heart attack risk and stroke risk as well. So this helps in overall health. Yeah. So now coming to how are we going to reach our health treatment goals that we had talked about earlier. One thing I like to tell my patients is that, yes, this excess body fat that we have is a medical disease. It's a medical condition, but it is treatable. It's something that we can manage. So, but what it does require is a lot of patient commitment. And with the help of, and if the patient is committed, with the help of a good medical team, a good management team, we are able to reach that goal that the patient is trying to achieve, so to live healthy. So the things that we target are the nutrition and their physical activity. So we like to tell them to improve their nutrition, get the right kind of food, make sure it's not calorie dense, stay in the calorie count, and be in a certain, we give a calorie restriction that, okay, let's stay in this calorie restriction so that we are able to achieve our goal. Physical activity definitely needs to be improved. A lot of patients are, because of their weight, don't want to go out. They don't want to go to the gym. They are unable to do certain things. So I think developing a good exercise plan for them is important, so that they are slowly able to do what they want to do. Another aspect of treatment and the management team is our behavioral therapy. So it is very important we give them the tools as to how they can log, what they can do when they have these urges to eat, and change their behavior, so that they are able to control their intake and they are able to exercise more. With just nutrition, physical activity, and behavioral therapy, we have seen that we are able to achieve about 5 to 10% of their body weight, the reduction in their body weight. Some patients need that another extra help with the medications or surgery. And with surgery, with medications, we can achieve a 10 to 20% of their reduction in their body weight. And bariatric surgery, of course, has a higher, reduction in the body weight with about 30 to 40%. So, yeah, so it's very important that we are able to target our population, and primary care identifies it and we are able to treat it, yeah.
So I just have a question, like what guidelines do you use for obesity treatment? So we've talked a lot about, like what we need to do, but more specifically, like what kind of guidelines do we use to try to help teach the patients? So
when we talk about guidelines of treating patients for obesity with medications and with surgery, anyone, an obese adult or a person with excess body weight with a BMI of more than 30, or someone with a BMI more than 27, with any of those medical conditions that I had listed before, if they have any of those health conditions, they are a candidate for medical weight loss, meaning with their medications can be prescribed to them to help them achieve their goal. And patients who have a BMI more than 40, or if they have a BMI of more than 35, and they have other health conditions, they would be candidates for surgical weight loss.
So, Dr. Singh, because I do weekly bariatric events with Dr. Erkan from CREAS, as you are part of our program. So all I do is just talk about weight loss and bariatric, and I dream about it and I remember everything about the patients, but just trying to kind of listen to everything that you said. And interestingly, like there's a regional factor, like when you are going, like south part of this country is more affected or impacted by morbid obesity. That's probably true for the south part of the state, right?
Sure. Delaware, in fact, has an obesity rate of 36.5%.
Mm-hmm.
So that's pretty high. Yeah. This is the 2020 data from CDC.
That's I mean, I find that very interesting. The age and the gender and the race, these are all have different impact. And also there's still this issue of people not understanding what patients are going through. Even their friends and families don't understand. So as you know, our other program is the Accountable Care Organization, and Donna and I, we run another set of case conference every day. And you were part of it. In fact, for a couple of times you participated. So in some cases, what we see is like morbid obesity is one of those chronic illnesses that's not being approached easily because there's still this discomfort. Like the physicians are still not comfortable, providers are still not comfortable. Just if the patient doesn't say anything, they don't want to say anything about the issue. So how are we going to break that kind of like habit so then people are just treating this just like any other patient who may have like A1C like 12. Like if you see someone with A1C 12, you would kind of freak out and then say, well, you have to see an endocrinologist now. But if you have a patient with BMI 52, you shouldn't let that patient leave the exam room without having a proper plan in place.
And we, because I've been practicing family medicine for so long and was also trying to incorporate obesity in my obesity management in my practice all along. Of course, patients, they, like I said, the patients who are very overweight or very obese, they do not really like to come to doctor's offices as much. But whenever we see them in office, I think that's a good chance of catching it. And, of course, has to be a comfort level as well with the patient. If the patient doesn't know you and you just talk to them directly and say, hey, what's going on? They don't want to hear it. And I understand that because it's a very touchy topic for some patients. So if it's a patient that you have been seeing over a long period of time and you have noticed that, say, the weight is progressively increasing. So a nice way to approach it would be to say, hey, what's going on? Who cooks at home? Do you eat out? Or, what did you eat yesterday? What did you eat? So that's how I start a conversation for some patients. When I'm seeing them for primary care, I would have asked, hey, so you just came in and what did you eat for breakfast? And then we just talk about it a little bit and then slowly build up on that. Of course, there's always so much time we have and we have trying to see patients, but then we can always call them back. Like, would you like to talk about it more? There are options out there. Things can be better and we can achieve that. You don't have to be using a walker just because now you are having difficulty walking because of the mechanical forces of the overweight that you have. So having the rapport with the patient is, yes, important. Just slowly building it up, and when we see that blood pressure is up. So that is another time when we can ask, so I see your blood pressure is trending up. You're on 3 different medications. If you could help just exercise a little bit, lower your salt, change your diet a little bit and lose some weight, that would help you with decreasing the number of medications you would be on and maybe get rid of the medications. And then if somebody is a candidate for medication for weight loss, or if somebody's a candidate for surgical weight loss, then we can, of course, refer them in that direction as well, if they are okay with it.
One last thing that I want to just point out, we have an accredited diabetes program in place. And that's also one of those, we don't see the problem much on the patients who are going through the bariatric surgery, because that's one of the requirements. But if they don't have to go through the surgery, then there's this hesitation that they don't follow through with the dietitian. And then you actually work best with the dietitians if you team up with them, if patients are going through regular visits with the dietitian. These are covered services by the insurances. And in fact, even if in some cases, if it's not fully covered, we are not really, our goal is to really help the patient. So that's not our bread and butter in any way. So we are not really going after the patients, so as long as they are able to participate. So that's the other thing that I see, that patients are not really taking advantage of that, especially with the telemedicine now. You would think that more people would be taking advantage of those events, those visits.
Yeah, and so when I see them back in office, I always ask what happened at the nutritionist visit or the dietitian visit. And many times we also refer them for behavioral therapy or psychology. And then I ask, okay, what did the psychologist say? And where are we headed with that? So, and there are now so many different apps as well that social media, or, we have that the patients can download on their phone, and that can help them as well. So there are a lot of resources out there, and we all, should try and help our patients the best we can.
Absolutely. Well, thank you so much for joining us. I know you were seeing patients today at the end of the busy week. Thank you for taking the time with us.
Thank you so much. Thanks for having me. Bye.
Thank you.
Bye.
All right. So after a lot of obesity, weight loss issues, let's break the ice with the loser of the week, right? So
Yep.
This loser is Alexander Zurev, who had a lot of anger issues, right? We knew him. He was in the news for beating his girlfriend, and then he was actually refusing all those. But then the other day he was about to, let's see if this is going to play.
Yeah, you could, it'll load maybe like the 45-second mark or so, halfway in, is kind of, because the clip here just shows the end of the match. But yeah, about halfway through, maybe like 40 seconds or so, you kind of see after they shake hands, he loses his temper there a little bit and takes it out on the judge's stand there.
So it's coming.
Yep, right after they're gonna shake hands, and you'll see.
He's such a long, and he's hitting the umpire. And he's not done yet because he's a loser. There we go. And he's an entitled loser. If he was black, he would be just escorted out. But he's a white guy. Then he's able to get away from this. When Serena Williams did the same thing without hitting anyone, she was being penalized so badly. So that I have to say that, but that's the case in sports. So, okay, so now I feel better. Now, someone who play college football, when you see something like that,
yeah, it's just, I mean, I'm not sure the circumstances of the match there, or what. I'm assuming he ended up losing, and was probably blaming a call or two on the official. But you kind of just can't let your emotions get the best of you. You have to remain, conscientious of your actions and the consequences that'll come along with them. And, it's kind of a mind over matter thing, especially when it comes to sports, of controlling your emotions, whether you're winning or losing. So.
Right, so it's important. So it has to. I mean, you have to stay professional, and that's the bottom line. So there's no excuse. You guys are making millions. I mean, that guy is. I think he's ranked 1 right now in the world. The thing is, it's the behavior. Like, so if he was in the paper, allegedly he was actually beating his girlfriend. So then he was saying that no, I didn't do it. Now, if I see that type of behavior, and then
if you were on the fence, I know which way you'd lean now.
Right.
Yeah. Exactly.
Well, maybe you did it. So.
Yeah, people are always watching. That's for sure.
Yeah. So, all right. Now, as we promised, for the remaining of the time, I think we have just enough time to cover economy. One of the interesting issues with us, every time we prepare these things. The trouble is we are being outdated with the new stuff. So we put this up because I personally am concerned about the economy. This had nothing to do with the war that just started. This was before. So when the national debt went up to 28 trillion a couple of months ago, and then it hit over 30 trillion. I was bringing those up, and I was sharing those with you guys in the office. And the inflation, we were feeling it. So inflation is kind of interesting. You may not feel the inflation in the like in the immediate stuff, like the food may not actually. You may not feel it. You may not feel the impact, but the bigger items that are coming slowly, but the impact is going to be felt maybe in time. So this is, one of the things for this one is the oil prices, the energy cost. And right now, Russia, what's happening in Europe is already impacting the oil prices by, it's already over $100 a barrel. So the prediction is about 125 to 150. So this is going to have a domino effect. So now this is not the reason that we were actually talking about this topic, right, Sean? So
right. Yeah. So initially, one of the things that kind of got us interested in the financial mini crisis here that we're kind of seeing was, our life expectancy for people and the retirement that we brought up on how people aren't necessarily planning to the best of their ability on being able to retire comfortably. And, we had mentioned a couple of weeks back how we are seeing people working beyond the former kind of accepted retirement age of, maybe early 60s to mid 60s. Now you're seeing some people, not necessarily by choice, but kind of they're forced that they have to continue working almost into their 70s to afford, because they're just going to be living longer. And I don't think that a lot of people were planning on, a retirement fund that would carry them into their 90s, say. So that's kind of what initially got our attention to it. And then obviously with what is going on now with current pandemic in the past 2 years, and now this most recent European crisis, people are going to definitely feel the impact of, number one, poor planning, and number two, just global events that are kind of out of an individual's control that you kind of have to respond to.
So the issue is we went through a pandemic and we are still going through, and that already has a big toll on everyone. Now this war coming to almost our way, and no one is going to win, and everyone is going to lose. Only if you are actually selling weapons, you are going to win. The cost of Iraq war was about 3 trillion to U.S. economy, and the Afghanistan was 2.3 trillion. These are new numbers. Now, when we just put almost 3 trillion just for the pandemic, without the war in it, so everything's going to be costing us a lot more. So telling this is coming is one thing, but us being able to preparing ourselves, and then also individually just getting ready and understanding what's happening, and then just be there. So then it's going to be affecting everyone less. Now I see people spending way too much money. I know how much everyone is making, but then they're on vacations, they're on this, they're on that, they're out and about, and that's gonna cost everyone at some point. So I don't want to just bring everyone's morale down, but I'm just telling you that realistically there are things that people can. The real life is not what you are buying with your credit card. What you make is your real life. So you have to live with your budget. And then this is true for countries as well. So when the gas prices already before war, it was already up 50%. So now it's going to be 100%. So, well, the insurance companies are not paying us more. So then we are not going to be able to pay our employees more. So if you don't make more, how are you going to actually pay for these extra expenses? So we have to actually make something individually, not just expect everything from our government. So government is not an independent entity. It is part of us. It is the people who are doing this on our behalf. Like, the cost of, the purchase power of dollar is already so low. So people are not feeling it, that they think that things are much better in the US. That's not. So everyone has their own issues. The inflation just became reality in the US. Every month, it's more than the month before. And actually, if the official versus the unofficial, it's probably twice more than what it is. So these are all real numbers. So that's what we probably want to tell you right before your weekend, so that you don't spend a lot of money. Next week, we'll be back with new items, new topics, and then we have Bariatric Friday with Dr. Erkan in 15 minutes. He and I are going to discuss the bariatric surgery and the resolution of other illnesses related to morbid obesity. So we have a good discussion coming up. Hopefully, we'll see everyone in 15 minutes. Well, thank you so much, Sean. Thank you for joining me.
Of course, yes. Thank you for having me, and hopefully everyone has a safe weekend and they're able to plan a little bit better for their future, and we'll see what next week brings us news-wise and where we're standing then.
Absolutely. Hopefully things are going to be better. Let's hope for that. All right. Bye-bye.